Hello and welcome to the Acute Medical Teaching Series. We are your hosts, Shifona
and Harrison,
both senior house officers from Salisbury District Hospital.
This is a 12-part teaching series running over the next 3 months. You can find links to the other sessions on our YouTube channel or via Blackboard for the local Southampton students.
This is our first session and we will be looking at atrial fibrillation today.
So what is atrial fibrillation? It is a supraventricular, so it arises above the ventricles, tachyarrhythmia with irregular and chaotic electrical activity in the atria. The muscles of the atria basically quiver or fibrillate instead of any coordinated action.
We won't go into the pathophysiology of AF in too much detail. However, there are several complex etiologies, including ectopic foci or a localized re-entry circuit. In a normal synchronized rhythm, the SAN, or the sinoatrial node, sends impulses to the AVN, or the atrioventricular node, which then travels down the bundle of His and up the Purkinje fibres.
In AF, ectopic foci are often located in the left atrium and the pulmonary veins. Discoordinated electrical activity emerges from these foci. The AVN picks up these irregular signals, causing an unsynchronized rhythm. Alternatively, re-entry circuits in the atrial myocardium, which can form due to reasons such as hypertension, age and heart disease, can also cause the AVN to pick up irregular impulses.
When we classify atrial fibrillation, we can categorise acute presentations into first diagnosed AF, paroxysmal AF, which lasts for less than 7 days, or persistent AF, which lasts for more than 7 days.
There are several risk factors for AF, which are important to think about during your assessment. These include increasing age, hypertension, obesity, and diabetes, among others. Men are also more commonly affected than women. Now that we have looked at what AF is, let's look at how we assess a patient with AF.
The most common symptom that patients present with is palpitations. They might also feel short of breath, dizzy, or have chest discomfort. Some signs you will see are tachycardia and an irregular pulse. Investigations you need are basic bedside tests, including observations, ECG, and blood tests. The ECG will help us pick up the rhythm that they are in and identify the AF, and the blood test will look for any causes of AF, including electrolyte disturbances, thyroid functions, signs of infections, and use an ease, which is useful to check renal function prior to giving medications. You can also consider the need for prolonged ECG monitoring, for example, if the patient is unstable or if the AF is paroxysmal.
Some differentials for AF include atrial flutter, where we'd expect to see a sawtooth baseline, multifocal atrial tachycardias, where you'd see a tachycardia with P waves of different morphologies, meaning that the impulse is starting at different places within the atria. And then you could also see a sinus rhythm with premature atrial contractions. This is when the atria, or the sinoatrial node in the atria, triggers a premature beat, but this is not AF. And you would expect to see a normal P wave and a normal QRS preceding this. The rhythm will just be irregular. You should also consider differentials for the other symptoms that the patient presents with, for example differentials for their chest pain, or their shortness of breath, or their palpitations.
The top ECG is that of AF, and the bottom ECG is a normal ECG. What differences can you see? Features of AF on ECG include an irregular rhythm, no P waves, a fibrillatory base, absence of an isoelectric baseline, and generally a narrow QRS complex.
When we talk about the management of atrial fibrillation, we talk about 3 different concepts, namely rate versus rhythm control, preventing stroke or thromboembolic events, and the management of the unstable atrial fibrillation. Later in the session, we'll go into much more detail about rate versus rhythm control, but broadly they can be defined as rate control equals trying to slow down the atrial fibrillation, so to bring the patient's heart rate down, but to accept that they're in AF. Whereas rhythm control means to try and take the patient out of AF and put them into a normal sinus rhythm. But first, we're going to be talking about the unstable atrial fibrillation as per the Resus Council guidelines. As part of the acute management of AF, we need to identify patients who have features of hemodynamic instability and life-threatening features as described by the Resuscitation Council UK's tachycardia guidelines.
If we follow this algorithm and do an A to E assessment of the patient, Anyone with these features, so shock, syncope, MI, and heart failure, will need a synchronized DC shock, followed by amiodarone if the first 3 attempts are unsuccessful. This should hopefully put them back into sinus rhythm. In patients with AF duration of more than 24 hours who are undergoing cardioversion, initiate oral anticoagulation for at least 4 weeks after the cardioversion.
Once we have ruled out unstable atrial fibrillation, we then move on to consider things like rate control, rhythm control, and preventing thromboembolic events. To begin with, we'll talk about rate control, where we normally start with a beta blocker, e.g. bisoprolol. If there are any contraindications to this, so for example asthma or a low blood pressure, we could also consider a rate-limiting calcium channel blocker such as diltiazem or verapamil. In patients with heart failure, you can also consider digoxin in this group as it is particularly effective. Note, however, each one of these medications has its own contraindications. We talked about beta blockers, but diltiazem and verapamil should be avoided in combination with other beta blockers or in patients with heart failure. And those given digoxin, we need to be careful of electrolyte abnormalities in this group and also other underlying cardiac problems such as Wolff-Parkinson-White syndrome. Whilst controlling rate, also treat for any other causes of AF, e.g. correcting their electrolyte status or treating their underlying infection which is driving their AF.
Alternatively, you can also rhythm control patients, either electrically or pharmacologically. Remember to check the patient's oral anticoagulation status as soon as possible. As mentioned before, in patients with AF duration of more than 24 hours who are undergoing the cardioversion, we would initiate oral anticoagulation for at least 4 weeks after. If rate controlling patients, you would consider anticoagulation if the duration is more than 48 hours.
When considering anticoagulation, there are 2 scores that need to be calculated to consider stroke versus bleeding risk. The risk of strokes we calculate using the CHADVAS score. We know these patients are at increased risk of stroke due to the fibrillating atria, which lead to impaired blood flow within the atrium and can lead to thrombus formation. And then we also consider their bleeding risk. As we'll be starting these patients on blood thinners, this is important to consider, and we can use either the ORBIT score or the HAS-BLED score, but the ORBIT score is more in fashion nowadays. The treatment should be tailored to the patient's risk factors.
So how do you decide between rate or rhythm control? The AF pathway on the Salisbury District Hospital's microguide is quite useful for this. So if we start with new onset AF, we can classify it as primary or secondary. We can think about treating reversible causes. If it's a primary AF, we would look at if the patient is stable or unstable.
We've already talked about unstable AF, so now we'll move on to the stable side of the guidelines. Rate control means that to manage the AF, we just try to reduce the rate the heart is beating at, whereas in rhythm control, it means we try to get the patient out of AF. When deciding whether or not to rate control or rhythm control in AF, we use the CHADVAS score. If they have a high risk of stroke, so this is a score of 1 or greater in men or 2 or greater in women, we would generally go down the rate control pathway. If they have a normal CHADVAS score, which does not indicate a high risk of stroke, then we'd consider the onset of symptoms. If the onset was less than 48 hours ago, we therefore know there's a minimal stroke risk in these patients and we can adopt a rhythm control method. However, if the onset has say been a week or longer than 48 hours, we would have to use rate control due to the stroke risk, due to the risk of there being a thrombus in the atria.
So for rate control, if the patient has a decent systolic blood pressure, so for example more than 110, and there's no evidence of cardiac failure, we would consider bisoprolol or diltiazem. If these features are not present, we would consider digoxin. Following the treatment, if the patient has a heart rate of less than 110 and remain asymptomatic, we can consider discharge.
For rhythm control, we'd only ever consider this if the onset of symptoms is less than 48 hours ago and the patient was symptomatic. This is because the longer you have AF, the higher risk you have of having a stroke, and we know that the highest risk of having a stroke is when we cardiovert you out of atrial fibrillation, essentially because a clot will fire off at that moment. Therefore, for rhythm control, it's important that we make sure patients have had less than 48 hours of symptoms, and we also give them a low-weight molecular heparin to minimise their stroke risk. We then have the option of either giving oral therapies, for example flecainide, or we can DC cardiovert the patient, depending on risk factors such as age, echo, and ischemic heart disease. Sometimes this can be successful, but sometimes it will fail, and if it does fail, we will then switch to a rate control method under the medical team. Whilst antiarrhythmic medications can be used successfully, they are not always tolerated or effective, and ablation procedures can be considered in certain situations, such as in symptomatic patients with paroxysmal or persistent AF. A catheter ablation uses heat or cold to burn and create scars in heart tissue to interrupt abnormal electrical circuits.
Another treatment option for some patients is atrial pacing. This prevents potential triggers for AF, so for example, bradycardic episodes and ectopic atrial beats. However, these options will be initiated by specialists, so are not relevant to the acute management.
Following on from stabilising the patient and treating with rate or rhythm control, you should refer these patients for appropriate specialist follow-up as per local protocol, i.e. to an arrhythmia clinic.
Patient education into lifestyle factors is also useful to minimise recurrence as it reduces risk factors. So for example, increasing physical activity, reducing alcohol and caffeine intake, and weight loss.
Thank you for attending our teaching session today. We hope this has been helpful.
See you next time.